Good afternoon, distinguished guests, respected doctors, colleagues, and friends. A very warm welcome to Allergy Matters Critical Allergy Identification and Clinical Decision Making. My name is Dr. Navenia, and I'm from Clinical Affairs at Pathology Asia Holdings. And I will be serving you as your MC today and also your moderator. Today's CME event is jointly organized by InnoQuest Diagnostics and Biomed Global and endorsed by the Allergy and Clinical Immunology Society Singapore. Allergic conditions are increasingly encountered across both primary and also specialist practice in Singapore and across the world. Despite this, allergy management remains challenging due to uncertainty over which laboratory allergy test to order, over-reliance on broad allergy panels with limited clinical value, and misinterpretation of positive results leading to unnecessary avoidance and patient anxiety. Today's program aims to explore the evolving role of practical, evidence-based laboratory allergy testing, helping clinicians translate test results into clear clinical action. So thank you very much for joining us today afternoon. I'm particularly excited for this CME compared to a lot of other CMEs I've been hosting. And I've gone through the slides. I'm sure a lot of you can learn a lot from our speakers here today. So stay tuned. And without further ado, let us begin. To begin our program, it is my pleasure to introduce our very first speaker. Mr. Anton Jansen is the International Scientific Advisor for Allergy and the Senior Scientific Affairs Manager for Sub-Saharan Africa for Allergy and Autoimmunity at Thermo Scientific. As Scientific Advisor, he oversees scientific matters relating to allergy and autoimmune diseases. Prior to this, he was involved in roles focusing on cell-mediated immunology testing. Today, he will be speaking on appropriate allergy testing in the laboratory. Ladies and gentlemen, please join me in welcoming Mr. Anton Jansen.
Well, good afternoon, and thank you for your very kind introduction, and thank you for inviting me to your country to talk, and also to InnoQuest and Biomed. It's a pleasure to be here, as always. So, I was asked to talk about, there we go, appropriate allergy testing in the laboratory, and this is so critically important to have the right test at the right time for the right patient in the different allergies. So, one back, as you can see, I work for Thermo Scientific, so that is my disclosure. Take care of allergy, specifically in the international region, and that's my passion, and that's why I'm here. So allergy is a worldwide problem, certainly increasing, and I can confirm that. Since I arrived here in Singapore, my rhinitis decided to step it up one notch. So it's really, really true. And you know it's a chronic condition, conditions such as allergic rhinitis, but we know it can also be life-threatening. We talk about conditions such as anaphylaxis. But the real sufferer is the patient because of an impact on the quality of life and, of course, on the health expenditure system in different countries. And allergic diseases are often misdiagnosed. We spoke about it several times already. And because it's misdiagnosed, it's mismanaged. And this mismanagement into maltreatment. So it's got a real knock-on effect on the patients. It's certainly a major global problem, and there's several articles outlining this with us. And you can see that they're talking about the prevalence of around 20 to 30% of the population, affecting both adults and children. This is huge, and I'm glad that we are in a position to make a difference in these patients' lives. So we often get asked, so what are the factors, what is causing this increase in allergy? And of course, because it's a multifactorial disease, there are so many things coming up. And once again, we were talking about some of them earlier. But the most common factors include reduced microbial exposure. So the hygiene hypothesis, the microbiome hypothesis, climate change, and with climate change comes different allergen exposures, environmental pollution, lifestyle and dietary changes. I'm from Africa, I'm specifically from Johannesburg, and we see these changes, it's got a huge impact. I mean, if you look at Africa and the urbanization taking place there, all these people are suddenly exposed to different new allergens in their lives. This is just a quick look at food allergy prevalence, and you can see this really worldwide. In North America, up to 11%, but in Asia, it varies between 1.1 and 10% up just for food allergies. So this is quite big. And this brings us to specific IG testing. And when we decide to test the patient, we take on a really difficult task here. Luckily, we've got tools, and these tools are there to assist us. But it's a bit like building a puzzle, because you have different pieces of information. You have total IG, you have the clinical history of the patient, you have the complete allergens, or the whole extracts, and you have allergen components. But when you build a puzzle, you usually have the box, and you can see the picture. In this case, we have no picture. So we have to figure this out from scratch and make sure when we're done, this picture fits. And that's where you as doctors come in, because this is really your part in this patient's diagnosis. So you all know the definition of allergy. We don't have to talk about it. All I want to say is that we talk about the immune system, we talk about IgE-mediated allergies, and sometimes these may be cell-mediated as well. So in conditions where we talk about drug allergies, drug hypersensitivities, or food additives, for instance, we need to consider basophil activation testing. But it all depends on allergen exposure, and this leads to sensitization. Such a small little word. But this word is so critical, especially when we interpret the results. So when we test for sensitization. The test result coming from the instrument report the specific IG value. And this is just a report on the level of sensitization. Sensitization does not equal allergy. Sensitization refers to the immunology side of things. But when we add symptoms, then we're talking about an allergy. And this is so critical to understand, and I think this is where we often see misdiagnosis, especially when we request inappropriate panels, we end up with positive results, and what now? Where does this fit in? Just some other considerations. Timing is important. Allergy is an evolving disease, but it's preceded by sensitization. And allergy changes over time. I always refer to it as taking a picture. If I test the patient today, it's like taking a picture of this room. When I come back next year, and I want to take the same picture, it's going to be different. Some of you might be somewhere else. There might be new people in the room. And this is what I mean with allergies in an evolving disease. Levels are really important. We know that high IG, specific IG levels are more prone to cause symptoms in patients. But it doesn't mean that low levels will not cause a reaction. Of course, each patient's got his own intrinsic sensitivity. There are cofactors. We spoke about it being a multifactorial disease. Cofactors are really important to consider, for instance, viral infections, medications, alcohol, and stress. Tolerance, a really important thing to remember in children. Children develop tolerance over time. They outgrow their allergies. And then, of course, there are several different mechanisms of allergy, which we also spoke about a little bit earlier today, like the type 4 hypersensitivity, so basal activation testing. But I think the message here is that you really need the history from the patient, the history of allergic reaction. If you add to that the sensitization, proof of sensitization, then we diagnose an allergy. And of course, all these results need to be interpreted and clinically correlated. So there are two things we can do here when we approach an allergic patient. First of all, keep in mind that we test for the presence of IgE, not clinical allergy. Even the cutoffs, when you look at the different cutoffs being used, for instance 0.35, 0.35 is simply a technical cutoff. It's never been suggested as a clinical cutoff. But because it's so well known, everybody's starting to use it as a clinical cutoff. Of course, allergy, there are so many different terms and it's been used very loosely. If we test for allergy, we test for the immune system. Everything else is not considered to be an allergy. But how do we start with this? How should we follow up? Or where should our thinking take us? If we consider possible allergy in a patient, there's two ways to do this. You can either go for multiple testing, so you test a huge panel of tests, and then we take it from there. The result is usually that if you do a shotgun approach, that the likelihood of an allergy is not very high in these patients, or could not be very high. So your true positives are less likely, and your false positives are more likely. In other words, asymptomatic sensitization. But if we do an allergy-focused investigation, so we start off with the history of the patient, and then we test based on that, the likelihood of this patient having an allergy is much higher. So we basically do a focused testing, and the result is that your true positives and your true negatives are more likely, but also your false positives and false negatives are less likely. So this is basically to summarize what I'm trying to say here. We need to make the results that we get back clinically actionable. There's no point in testing a patient if we don't intend to do something with these results. One of my professors always said, the intention to test is the intention to treat. So there's two ways, two different thinkings here. The first one is to do indiscriminate testing, and these results are difficult to act on. And why is that? It's because we can detect sensitization without clinical relevance. And the result of this is that it's difficult to interpret the results we get back from the laboratory. Of course, this then results in overdiagnosis and often unnecessary avoidance measures. It is harmful, especially if it's used in a first-line test. There are tests available that can test for hundreds of allergens at a time. But the question is, what do you do with what you get back? And how do you make sense of it? There are, of course, other things like unnecessary referrals. It's got a lower sensitivity as well. The end result is uncertainty in diagnosis and patient management. If we do this in another way, if we do the targeted testing based on the patient's clinical history and considering the patient's environment, then it's got a different outcome. These results support clinical decisions. It's guided by the clinical history. Of course, I work with Thermo, so I talk about the immunocat test. So if you use the immunocat test, these will provide you with quantitative results. You get an actual true value. And these results are clearly easy to interpret. There are many guidelines on this. There's decision cut points that's all been referenced. So when we do this, it makes our lives a little bit easier. And of course, importantly, it's aligned with guideline recommendations. So when we follow this process, the result is confidence in diagnosis and in patient management. So I thought I'll just give you a quick overview on the most common technologies used. For instance, the fluorescent enzyme immunoassay technologies or the line immunoassays, which are very common assays as well. And of course, there are many different differences between these different technologies. But I think the most important ones are the way we detect the antibody, the type of test, whether it's quantitative or semi-quantitative, the limit of quantitation, so how sensitive is this test, and of course the solid phase capacity. Now the solid phase capacity sounds like a very technical thing, but what it boils down to is how sensitive can this test measure? In other words, can you capture all the total IgE or specific IgE antibody in the sample? And for this, you need a high binding capacity, a solid phase, where you can bind a lot of antigen to be able to detect the specific IgE antibodies. Now, there's a lot of pros and cons on this. I think I just want to highlight one other point. So if you look at quantitative versus semi-quantitative assays, a quantitative assay is something that is calibrated against a specific standard. For instance, in the ImmunoCAP system, we calibrate against the World Health Organization's human reference preparation for specific IgE. So whatever you measure is precise and accurate, and the values are precise. If you talk about a semi-quantitative assay, like we find with the line immunoassays, it gives you more or less an idea. It's not a direct comparison. The results kind of there, but it's not accurate. And this, of course, have the impact that you cannot follow up the patient, because the results can be more or less in the same range again, and there's no way to see whether it goes up or down, what the case may be. This refers to the binding capacity. So in a single-plex test, we test only one allergen. So you have one little test cap with one specific allergen in there. You have a very high binding capacity. So you have lots of excess allergen available for the IgE to bind. And whether there is competitive binding or not makes no difference. There's still enough binding capacity for the specific IgE to bind to. In multiplex assays or line immunoassays, you have allergen restraint. There's a limited number of allergen coated on these tests. And the effect of that is that you lose sensitivity, because if there's any competitive binding, there's no place for the IgE antibodies to bind. So why should allergy tests be done? There's a lot of words on here. You can read through it quicker than I can. But it boils down to confirming allergic sensitization, which is important together with the history to make the diagnosis of an allergy. We need to identify the trigger allergen, because this gives us information. There was a paper published on asthma not too long ago. And this paper said that less than 39% of patients get information from their doctor on how to manage their allergy and what to avoid and what to do about it. So that's quite a shocking statistic, and this should help us with that as well. Of course, we want to identify patients whose symptoms cannot be attributed to allergy. For instance, in the case of unnecessary drug therapy, roughly 65% of patients with allergic rhinitis or with rhinitis end up with a prescription for antihistamine, which could have been avoided right from the start. The results will guide clinical management, really important, especially when we talk about the selection for allergen immunotherapy, since this is really the only disease-modifying treatment for a patient. We can do risk assessments, we can do dietary recommendations, And of course, specific IgE is also helpful when there is no skin prick testing available. When we talk about support precision allergy diagnostics, here we refer to allergen components. This is really where everything is going to. Allergy components open up new doors for us, new ways of exploring allergy, new ways of deciding how to treat the patient. And I'll show you a little bit about that a bit later. But the important thing is we can differentiate between true allergy and cross-reactivity. We can do a risk assessment, we can predict the risk of a patient having a reaction or severe reaction or not. And then lastly, patients can be reassessed over time. Now this reassessment, that concept also came up in the latest EARC guidelines, where they specifically, for the first time, mentioned that patients should be reassessed at regular intervals. So, talking about the guidelines, there are many guidelines available at the moment, and I'm just going to talk about the ARCI guideline to make things a bit easier. But they all have the same message in common. And that message is that testing should be selected based on the medical history and should not include large screening panels. This message you'll see right through all the guidelines internationally. And they say that more is not always better, and I'll show you a little bit why that is. So if we look at the ARCI guideline, for instance, they talk about the clinical history being really important, and indiscriminate panel testing should be avoided. Of course, it's got a place. If we want to do a big panel, or test a big panel, we should just select the right patient for this. And to be honest, we should also let the right doctor handle this, because this can be very difficult to interpret if you don't have sufficient knowledge on molecular allergology. So we use these in cases of cross-reactivity and multi-sensitized patients, or cases where we could not get history from this patient and we do not know what caused the serious reaction in patients. So these were the 8 evidence-based recommendations in the ARCI guideline, and you'll see I'm just going to highlight some of them. In terms of diagnostic tests, they said it should be history-based. Recommendation number 3, we spoke for the first time about adding certain allergen components to aid us in the diagnosis of patients, but also to get a clearer picture of the patient's sensitization profile and to guide us in the management of these allergies. And then recommendation number 6 talks about reassessment of food allergic children at regular intervals. Now that regular intervals was a bit vague. Of course, being from Thermo Fisher, it would be great if you can do it every second day, but that's not feasible. So we did a bit of a systematic literature review, and the results vary. So depending on the different allergens, it's anything from 6 months to every year that these patients need to be followed up. But then they broke it down. If we look at the recommended sequence of tests in the laboratory, they were very specific about this. So they recommend that you start off with the clinical history plus testing with its specific IgE or skin prick testing based on the patient's history. These are your first line tests. And for this you can use, for instance, all allergens, you can use mixes. They were pretty clear on that. Whatever you find in this first round of testing will be implemented in the second round of tests. So once you identify the trigger for the whole allergen, we move on to molecular allergology or molecular IgE testing, where we look at the allergen components individually. And once again, they recommend that we do singleplex tests. So you test milk positive, go and look at casein, for instance. But do the singleplex. Don't do a big panel of tests. That simply does not make sense. But it is not totally impossible as a third line testing. Depending on what we find here, if you find here that this patient has multiple sensitizations, then we can certainly move on to multiplex testing, and it's actually indicated by the guidelines as well to do a proper workup on these patients using multiplex testing. I often get questions about IgG tests. Does IgG testing have a place in the diagnosis of allergies? Well, IACU was very clear on that. The recommendation number 5 said it's recommended against the use of IgG due to a lack of evidence, and there's no rigorous validation to support these tests and the findings from there. And it was a very strong recommendation against these tests. Of course, they were not referring to specific IgG4, which does have a place in allergy, especially in allergen immunotherapy, when we follow up these patients to see whether the allergen immunotherapy is effective or not. And that's why I briefly had one slide here on specific IgE. And we see that the increase in IgG is certainly linked to natural or AIT-induced tolerance development. Allergen immunotherapy will certainly induce IgG4 production, but there's a whole cascade of things happening, including our regulatory cells, which got an effect on many other factors as well, in the end producing specific IgG4 and decreasing specific IgE levels. The responses here in IgG4 vary with the dose, allergen immunotherapy, the timing and the duration, and we can measure it periodically. For instance, if we do house dust mite immunotherapy, we often see that in the first 4 months there's a dramatic increase in specific IgG4 antibodies, indicating a good immunological response to allergen immunotherapy. You might not always see a decrease in the specific IgE level, but the important part is the strong increase in IgG4 antibodies. If there's no change, then of course there's a low probability of success of allergen immunotherapy. And since it's not cheap, it is quite important to follow up on this. I spoke about the interpretation briefly, and if we look at the correlation between the likelihood of an allergy from the test results versus the likelihood of an allergy from the patient's history, of course you have easy cases. If there's a high probability from the test results, but also high probability from the history of the patient, it's very likely to be an allergy. Or if there's a low probability from the test results as well as from the history, it's unlikely to be allergy. But why must it be now easy? We sit with these cases. And this is where provocation tests will then help us a lot. Or if we do component testing, this can also shed some additional light on the patient's cases. When we look at specific IgE testing from the ImmunoCAP system, this is very clear. This shows us the correlation between the IgE antibody and the probability that this patient will react at a certain specific IgE level. You can see here that even at the cutoff of 0.35 or 0.1, depending on what you're using, there's still a probability that this patient can react. And we need to consider the age of the patient, especially in children. In children, this graph will move to the left. And there's certainly a high probability that the patient, for instance, will react to egg if they're younger than 6 months of age. Even at a value of 0.1, they have about a 20% probability to still have a reaction to egg. But these results are very clear and easy to explain to the patient. And to help us, we've got some decision guidelines. These are the decision cut points used in the US. And they are also clear. So you can see 95% probability. This is the blue regions here. So if you find, let's say, egg positive above 6, there's a 95% probability that this patient will have a positive reaction to egg in a provocation test. So it guides us and it helps us a lot. Iaki went one step further, and they decided to add not just the specific IgE, the complete extracts, but also the allergen components. So here you can see this block here represents the allergens that was suggested to be added, or where you should add component testing. So this is really going to help us a lot, and this is from a meta-analysis, meaning that we can use it in most parts of the world. The added advantage is that these were performed on a immunocap system, and there are many studies especially indicating that results on different systems cannot be used interchangeably. And the same with decision cut points. You can only use them if you use the immunocap system. Any other system, you need to figure this out for yourself. So I just briefly wanted to show you some advantages of using allergen components. So this is a classical situation. We have a patient presenting with symptoms. We test all allergens or skin prick tests. And then based on this, we either do challenge testing, or we come up with management strategies for the patients. We suggest to them, listen, you're allergic to milk, so cut milk out of your diet. But if we add allergen components in there, it opens up a whole new world. You get a lot more additional information out of it, and we end up with optimized patient management. So how do we look at component resolved diagnostics? I thought we'll use the example of cholesterol. If you test total cholesterol, is that sufficient to know what's going on with the patient? That's not. Because we need to know, is it, what are the levels of HDL, LDL, triglycerides, and it's the same for allergens. If you test a whole allergen, like milk, and it's positive, we need to know what tested positive in there, and what's the probability of this patient reacting. What can we tell the patient differently? So, for instance, if it's milk, can this patient have baked milk or not in baked products? So it adds a whole new dimension of information for these patients. So what we basically do, this is an example of peanut in the complete extract. For the whole allergen, you have all the different proteins contained in one test. In the case of allergen components, we can take them individually, place them in one cap, and test only that specific component. Still in the singleplex platform. Come on. So this is basically just an example of what do we mean by component resolved diagnostics. If you take 3 different allergen sources, you'll find that some allergens will be very specific to the source, and others will be cross-reactive. In other words, found in all the different allergen sources. So in this example here, you can see your birch pollen, the peanut storage proteins are very specific. These will not cross-react with other components. For instance, these cross-reactive components, and they will not cross-react with birch or peach allergen components or allergy. But your cross-reactive components, PR10 and LTP, these are the ones that are messing around with us. They cause a problem in our tests, but they also cause a problem in patients. And this is what they do. Component resolved diagnostics will help us to distinguish between a true sensitization or a cross-reactivity in these patients. And here's just a quick example of how does my resolved component resolved diagnostics. So the patient show up, with symptoms, we test the whole allergens, D1 and D2. What's next? We can either stop here, or we need to decide are we going to continue with allergen immunotherapy or not. So now we can continue with the components and do DERPI1, DERPI2, and DERPI23. And of course there's DERPI10. Now DERPI10 is your cross-reactive allergen. This is a tropomycin, and you find it in many different allergen sources, including some seafood. You find it in crustaceans, insects, and mollusks as well. On the other side, you have your primary sensitizers. So these are the ones responsible for the patient's symptoms, and sometimes these patients are monosensitized to them. If you look at the choice, how will this affect the choice of allergen immunotherapy? It will allow us to differentiate between DERPI1, 2, and 23 because we can now test them individually. And it will help us to choose the appropriate allergen immunotherapy. For instance, in DERPI23, the amount found in the fecal particles in the bodies of mice was significantly lower than the other components. The effect of this is that patients will probably not respond to allergen immunotherapy because these, DERPI23 specifically, is underrepresented in the allergen immunotherapy available. If it is a cross-reactive component testing positive, there is no point in giving this patient allergen immunotherapy. We should rather go and look at other places. We should go and investigate a food allergy, just as an example. So I just wanted to show you that this is going to have a major impact on how we decide the course of a patient's management. This is just one example. There are many examples of many different allergens available. And I hope I gave you a bit of insights into component resolved diagnostics, which tests to request, what happens in the background in the laboratory, and what can we find and what can we learn from the way we approach the patient and how we think about requesting these tests. And I don't know if is there time for questions, or do we do that at the end? Okay, that'll be at the end. Thank you so much.
Thank you very much, Mr. Anton, for that insightful presentation. Okay. Now, let us move on to our second presentation for today. It is my pleasure to introduce our second speaker. Dr. Peng Kaitian is an associate consultant with the Pediatric Allergy Service, Department of Pediatric Medicine, KK Women's and Children's Hospital. She specializes in pediatric allergy with a focus on food allergies in children. Dr. Peng obtained her medical degree from Duke NUS Graduate Medical School and completed her postgraduate training in pediatric medicine, receiving specialist accreditation in 2025. She holds a postgraduate qualification from the Royal College of Paediatrics and Child Health UK and the National University of Singapore. Her clinical and research interests include food and drug allergies in children, oral immunotherapy, and allergy immunology, supporting her work in advancing the understanding and management of pediatric allergic conditions. Today, she'll be speaking on food allergy testing and interpretation, pearls, and pitfalls. Please join me in welcoming Dr. Peng.
Hi, I'm Kaitian, and thank you for the kind introduction, as well as to the organizers, ACIS, ImmunoQuest, as well as Biomed, for giving me an opportunity today to share on the topic close to my heart, which is IgE testing for food allergies. So basically, this is my declaration. I have no conflict of interest, and for patient confidentiality reasons, there will be no patient actual pictures or identifiers labeled in this slide today. So in terms of the talk, today it will be structured over three parts. First, we'll be talking about the interpretation of IgE results. Dr. Jansen has very kindly just now went through with us how to go about doing the IgE testing. This will be more of the clinical context of how to interpret the results when it actually comes back to you in the clinical setting. And I'll be going through a series of patients that I personally have seen before. Subsequently, we'll go into some of the advances in food allergy management, including biologics as well as the hot topic, which is allergen oral immunotherapy, because I'm sure there'll be patients whom you'll see in the primary care setting who will ask you about all this, because all this information is now very widespread online on AI as well as in other countries. Next would be that of the rarer phenotypes of food allergy, but should not be misdiagnosed or undiagnosed in the primary care, and they often still present to the primary care setting as well. And you guys are the first line of defense. And hopefully this will also bridge nicely into Dr. Gray's talk subsequently, talking about environmental as well as food allergen interactions. So in terms of food allergy, I will not belabor the point. Our first speaker has really gone through. It is considered the second wave of the atopic epidemic. It is often present in early childhood associated with concomitant atopic conditions such as the eczema, otherwise known as atopic dermatitis. It is actually becoming increasingly common in the current generation, whereby in Singapore, nowadays the self-reported data based on prevalence is 3 to 4%, which is quite significant, and it can present as early as infancy. However, overdiagnosis is also very widespread, and IgE results, as mentioned earlier, are often misinterpreted. These are the common 8 food allergens that our local population is known to be allergic to. And this misinterpretation of IgE results is critical because it leads to a lot of unnecessary food avoidance for a growing child that obviously can compromise on the nutrition of the child, and it leads to a lot of significant parental as well as childhood anxiety about food, which is a critical part of life, and as a result, it leads to reduced quality of life. And the worst scenario is that it may lead to the development of more and more food allergies in the same individual because of prolonged unnecessary food avoidance. So as with any test that we send off, if we send it off, we do need to understand the test characteristics in order to be able to interpret it well. Thus, I'll bring you all back to some concepts, probably was from a long time ago back in medical school, sensitivity versus the specificity of the test. I'm sure all of you remember the 2x2 table and having to calculate all this for MCQs at that time. So basically, a sensitive test is one that is good at detecting disease presence. It minimizes false negatives. However, a very specific test is more for ruling out disease absence, and it minimizes false positives. So what is happening with the IgE test is that it's a very sensitive test, so it's very good for ruling out the disease, but however, it's also known to have very poor specificity, so it's very prone to false positives. So what it basically means to the patient and to you is that it's a test with good negative predictive value, but very poor positive predictive value. So the first speaker already emphasized IgE test basically detects sensitization, and sensitization basically just means that this is a presence of IgE against a particular food allergen. It is definitely not diagnostic of clinical allergy. There are patients who have a positive IgE test result, but yet can tolerate the same food under the clinical setting. And the IgE levels just predict a probability of a reaction. Any number more than 0.35 yes means that it's positive, but if you have seen any of these reports, the range of values reported can be anything from 0 up to more than 100, whereby the lab just didn't bother to report because the levels were too high. And basically, they can be interpreted in many ways then. Thus, if you have a low level of IgE, it's a low probability of reaction, and a high IgE will then be a higher probability of a reaction. And actually, all this sensitivity, specificity, positive, negative predictive values of all these tests actually vary widely between the different allergens studied as well as the different populations. So for instance, in this paper that I show you here, you can see that even for the common food allergies such as milk, egg, as well as fish, the cutoff values actually vary very significantly from level less than 1 to single digit to double digit, and the corresponding area under the curve, as well as sensitivity, specificity, positive predictive value, and negative predictive value is actually highly variable. And thus, the interpretation of these IgE results is actually not as straightforward as it is. If it would, AI would have taken over our jobs, and my life would also probably be much easier. Is that the interpretation of these IgE results really does depend on the pre-test probability, thus the emphasis on a good clinical history, knowing the population, the demographic study, as well as the cutoff values, which can vary very widely. So I will try to come up with a simple stepwise approach approach towards interpreting IgE results. So first, it's important to relate it back to the patient. What is the patient allergy-focused clinical as well as dietary history? Thus, it's important during the history-taking process as a clinician to understand what is the history of the allergic symptoms experienced, what was the temporal relationship of it to allergen exposure, as well as to response to treatment such as antihistamines or even IM adrenaline. In addition, the detailed dietary history is very important, especially in the pediatric patient. What are the usual dietary patterns for this child? Has this previous implicated allergen already been tolerated? Has there been any cessation of this allergen intake prior to the reaction? Or has there even been continued consumption without any problems after this initial allergic reaction concerns? And also check if the IgE obviously matches the suspected food and assess the IgE levels, whether they are low or high. And the next thing would be to ask about tolerance to any co- or cross-reacting foods, other cofactors such as that of any intercurrent illness, any viral infections, as well as any exercise, for instance, as well as the allergic background and the allergic comorbidities of the patient. So I will not delve too much into the details of allergy associations because I think that is a whole new topic on its own that has a very broad scope. I think for the primary care setting, what would be useful would be these three main associations, which is egg is associated with peanut, peanut is associated with screen nut, and then the grains group, which is wheat, is associated with oat, barley, and rye. And for this one, the ease of remembering it is the patients will usually just come in and talk about gluten because that's how they remember it. So moving on to the common pitfalls before I go into the patient case studies. So some of the common pitfalls is to do whole screening food panels for IgE without any history because then they are prone to pull up multiple false positives that makes it very hard for you all to interpret and then to give a clinically meaningful answer to the patient. The other thing is to screen for food allergy and atopic dermatitis randomly because these patients are very high at high risk for food sensitizations and food false positives because of the defective skin barrier. And in fact, it's reported to be as high as 60% of sensitization in eczema patients. Next is to misinterpret a low positive result. Sometimes a low level IgE can be clinically irrelevant. And also using IgE to predict severity because it cannot really 100% reliably predict anaphylaxis unless it's at the extreme ends of the result spectrum. And the other common pitfall is often not considering other differentials. So for instance, in a young child, vomiting can be due to anything as simple as esophageal reflux disease, can also be due to colic, can also be due to something more sinister like pyloric stenosis or intestinal obstruction. It does not always equate to vomiting, diarrhea equals to a food allergy. And the other main pitfall is that of recommending long-term untargeted elimination of foods because for a growing child, this would significantly be detrimental to the patient's health as well as quality of life. So now we're going to a patient case series. So first of all, this is patient M. You'll find that my patient's base is basically very pediatric based because I'm a pediatrician. So this is a 5-year-old girl. She has a background of severe atopic dermatitis on topical steroids. Previously, they saw a pediatrician for parental concerns of food allergies triggering her eczema. However, this child actually has no previous history of any food allergies. She's known to tolerate most food allergens with no problems because she's quite an old child already. And then in terms of the panel of IgE, the PD has sent off a whole panel of IgE to food allergens, told the parents that it came back positive for cow's milk and egg, and then the parents were then advised to stop all cow's milk and egg in the child's diet. The parents actually did comply, but however, they felt that there was not much change in eczema control on and all. It still flared, and in retrospect, they were now recalling that, I think it always flares whenever my child is unwell with some viral infection. So now the PD is retiring, so the parents want to seek continuation of care and came to see you instead. So what would you do? So this is not an MCQ quiz, so it doesn't mean that there's one specific correct answer. It really is just to trigger the thought process. So would you continue cow's milk and egg avoidance and then follow up eczema? Or you're not sure what to do? Never mind, just refer allergy first. Or C, repeat IgE testing. Maybe there's another food allergen that they are not eliminating. I increase my panel. I can increase it to 40, 70, and I look for more culprit foods to eliminate. Or the last thing is to repeat the skin prick, and I do an IgE, but now if it wasn't previously done, I will do an IgE, total IgE, and interpret it all into context for the IgE results. So for this patient, what I did was that, because in KK we can do the skin prick relatively easily and the results will be out the same day, I didn't bother with the IgE, which takes a few weeks to come back. So actually I did a skin prick and the result came back as negative, even though the kid has been avoiding for a while, fortunately. So So basically, I just told the kid to continue reintroduction of the food at home, and I opened it them, and so far they haven't come back. So the next patient is a 5-month-old boy. This is also a very common scenario that I think you often see in the outpatient setting. This is a well baby who was born to parents who are both significantly atopic. So both daddy mommy has allergic rhinitis and eczema. So the mother has shellfish allergy, the father has peanut allergy. The baby is now exclusively breastfed, he's thriving very well, has some mild atopic dermatitis, nothing too bad, can be controlled just on topical emollients alone. So now the parents are starting to wean the baby and they are planning to do it in 1 month's time. But prior to weaning, they come to see you in the primary care setting as part of the well baby examination, requesting for allergy testing to food allergens given the significant family atopic background. So they're also asking for weaning advice. So what would you do? Send, as parental request, send the IG the whole food allergen panel. Any return positive, tell them to avoid the said food the kid is likely allergic. Or B, hold off testing, but you tell them delay introduction of common food allergens till at least 1 to 2 years of age, given that there's a strong family history of atopy. Or C, reassure the parents and tell them for early introduction of common food allergens when weaning and avoid food products in the topicals. Or D, refer allergists wean on safe foods like fruits and vegetables first. So the thing I would like to emphasize here is that first, in terms of weaning diet, nowadays in view of the LEAP study that was done in 2015, we no longer tell atopic patients or patients with atopic background to delay introduction of common food allergens. So instead, it is not to delay or even early introduction of common food allergens when weaning, just wean as per normal and but watch out naturally for allergic reactions. And the other important thing to emphasize is that of avoiding food products and topicals. Because nowadays parents are all natural, everybody wants the almond oil, coconut oil, avocado oil, all kinds of food oils in the topicals, but these actually do these kids more harm because it leads to sensitization of the food allergen through the skin, and then it subsequently leads to food allergies when they actually take in all the food through the gut. And in terms of safe foods, in general, fruits and vegetables are not very prone to food allergies in the pediatric age group. Thus, usually if we ever see food allergies to carrots, spinach, potato, pumpkin, for instance, usually we take it with a grain of salt and we hunt harder in the history to look for something that's more likely. So this is another very common scenario because this is one of the most common food allergies in Singapore, egg allergy. So this is a 1-year-old child, at 6 months old, she tolerated 1 hard-boiled egg yolk, subsequently ate the same hard-boiled egg yolk a few more times, no issues. At 8 months old, now given half a hard-boiled egg yolk plus white, so the whole egg, and then 30 minutes later had generalized urticaria, otherwise no angioedema, no anaphylaxis. The usual diet is the usual Asian weaning diet, is infant formula, rice porridge, some baby pasta with vegetables, fish, chicken, tofu. If not tried other food allergens. So in the primary care setting, we have been concerned of egg allergy and we sent off IgE for the common food allergens. The IgE results return as follows. I'll let you all take a time to appreciate the results, and then this is the interpretation of the results that the lab would routinely just provide you with, whereby anything more than 0.35 is positive, but there's a whole range of what is considered different class and degree of positivity. And then the parents are now staring at you wide-eyed and then ask you, doctor, how this result, what are you going to do about it? So how would you advise the parents? Unsure, you refer allergy, or avoid all IgE positive foods, or avoid IgE positive foods except those already tolerant. IgE negative foods can introduce, or only avoid egg, given that that's the one, the clinical history, avoid everything else since I don't know. So in general, I would say that I will avoid egg. There's already a clinical history, the IgE results were positive. At this point in time, I will usually tell them to avoid peanut because egg allergy is associated with peanut allergy. The IgE for peanut was positive, so then they will need further workup before assessing whether this child is indeed allergic to peanut or not. Anything that's tolerant and taking regularly in good amounts, I usually don't tell them to stop, even if the IgE is borderline positive. And if it's negative, the chance of reacting is low, they can safely do home introduction or to try it at home. So basically in the primary care setting, I think of some scenarios of what would prompt you all to refer to allergy. I would say any history of anaphylaxis, those are high-risk cases, they should be managed in a specialist setting, or if there are multiple food allergies, because these patients are often complex and it takes quite a fair bit of input to try to titrate what they can start, when they can start a certain food, or if you're uncertain of the diagnosis or unclear trigger, or if you have already set up the IgE and taken a history, there's a discordance between the history and IgE results, because there may be a need to diagnose the oral food challenge via the gold standard, which currently is that of oral food challenge, or the need to perform, as mentioned, component resolved diagnostics to further evaluate, or if the child has real food allergies, there may be a consideration of the need for oral allergen or immunotherapy. So moving forward, this is my chance to sell a bit of Goyo. So basically, currently there has been some advances in treatment of food allergies. In the old days, like Mr. Anton had mentioned, it really was just food avoidance. The way I look at food avoidance, telling patients just to avoid food, because your food allergy is just equivalent to just sit there, do nothing, pray to God, and then hope that God will bless me and let me outgrow. Allergen oral immunotherapy is the only disease-modifying treatment we currently have for food allergies, whereby what we actually done, the concept of it is that you introduce the oral allergen to the patient in graded amounts over time, so as to hopefully train the immune system and help the immune system reach what you call a desensitization phase, whereby they gain clinical tolerance to the food, or even better still, sustain unresponsiveness, whereby this tolerance continues even with the period of cessation of immunotherapy. And we currently have oral immunotherapy programs ongoing at KK, so if you have patients who are interested, please refer them to us. We currently have for cow's milk and peanut, and then there are more to come for some food allergens that we are working on, so more akan datang. And in terms of biologics, I thought this was just something to mention briefly, because there nowadays with AI and a lot of medical tourism, we are starting to see a lot of patients who have read out about what these new up-and-coming things with regards to biologics, the management of allergies in general, and thus they are starting to come to clinic and we ask questions. So in terms of food, and there are multiple biologics out there, including dupilumab, omalizumab is one of them in food allergy. So basically, just a quick overview, omalizumab basically is an anti-IgE. What it does is that it binds to circulating IgE so that it decreases the cell-bound IgE, as well as decrease the expression of the high-affinity receptors, which in the case of IgE is the Fc epsilon R1 receptor that's found on mast cells, eosinophil, and basophils. And in general, what they overall do is that they reduce the allergic mediators release reduction, as well as reduce allergic inflammation. So in the Western world, they have been proven to be very effective, whereby in this recent paper in 2024 in New England Journal of Medicine, they showed that in children even as young as 1 year old with multiple food allergies, just giving omalizumab for 16 weeks compared to placebo was really that good, effective at increasing the reaction threshold for peanut and other common food allergens. Omalizumab is licensed in Singapore for use. However, I think in our local context, what's holding the patients back, at least in the pediatric age group, from taking up this treatment is that unfortunately it's an injection medication and it's expensive. So I'll move on to the last part of my talk today, which is talk about rarer underdiagnosed food allergy phenotypes, which all of you may still see in the primary care setting, just so that it doesn't go unnoticed if you ever see such patients. So the first patient is a 16-year-old boy. I kept true to my promise. This is not my real patient. This one was a clipping from the Straits Times back in April this year, 2026, whereby they talk about this medical mystery, and then this child basically had something that was similar concept. So basically, for my patient, this was a previously well child. He actually went to the GP. Most of them go to the GP as the first point of contact because they have anaphylaxis, right? It's life-threatening. They need to see a doctor soon. So they have generalized urticaria. He had shortness of breath, the sets already borderline, was hypotension, and the GP very naturally and rightfully gave him IM adrenaline with good response. This child actually is completely not atopic, no known food or drug allergies, and when you explore the history further, nothing very significant. Then he just said, I had my lunch, fried chicken noodles in school, I ate from the same store 20 times before, no problem. I cycled past home subsequently before all this happened because I was running late for tuition. Sounds like a very routine Singaporean secondary school boy story. So what this child had in the end was that of this food-dependent exercise-induced anaphylaxis, which is otherwise what we call FDEIA for short, whereby the pathophysiology is that due to a leaky gut, when the child exercises, exerts himself, there's increased absorption of allergens that then kickstarts this whole allergic process. So these patients, they can actually exercise or tolerate a specific food separately. However, if they were to exercise 4 hours within the consumption of the specific trigger food, or the trigger foods are consumed right after exercise, they become symptomatic. And there is a known correlation between the increased intensity or duration of exercise and the risk of allergic reaction. The reason why it's often forgotten is because, unfortunately, the most common onset is during adulthood, even though it can happen in adolescence or in infancy even. And thus, as most people think of food allergies as a pediatric child condition, they don't think about it when they see the much older child suddenly presenting like that. The most common food allergen implicated is actually wheat, even though other common food allergens like cow's milk, peanut, and has been implicated as well. And important thing to note is that these anaphylactic reactions tend to be very severe. They can involve both the cardiovascular and respiratory system. And if you ever see them in the GP setting, always fall back to your basics, manage as per anaphylaxis does. So the next patient is JZ. This is a 12-year-old girl. This child is, this kind of story, I'm sure the GPs have also heard of it. It's very commonly seen, whereby this child has a background of poorly controlled allergic rhinitis, also has house dust mite allergy. Now she comes to see you saying that, hey, I don't know why late doctor, now I have a lot of shellfish concerns. Previously when I took shellfish, I had no problems. And in recent years, whenever I eat it, my mouth will itch. I don't know why. So you send off an IgE testing for shellfish and it came back as 2.1. So basically what is happening to this child. So actually the symptoms are explained for by this concept called oral allergy syndrome. So basically these are usually IgE mediated immediate symptoms that consist, they are confined to the oral mucosa. So mainly things like itching, stinging, and unfortunately sometimes some of them may complain of throat tightness and keep thinking there's anaphylaxis, and they get unfortunately labeled as idiopathic anaphylaxis. And the reason why, and as to the scientific basis why they get these symptoms is that there's actually IgE cross-reactivity between allergens. In the tropomyosin, in the shellfish, in the muscle that helps them contract, and versus that found in house dust mite, cockroaches, and other insects. And so the inhaled tropomyosin from the dust mite then acts as a primary sensitizer for this shellfish allergy because your immune system basically can't tell them apart. So patients like this usually will have a history of allergic rhinitis. Sometimes if they had done skin prick previously when they were younger, there may have been some dust mite sensitization, and when you do the skin prick or IgA to shellfish, it can actually be negative or low positive. But usually for these patients, they usually would just avoid because they find it very irritating to eat a shellfish. And coming to the last case that I'm going through today, this is an 8-year-old girl, and the syndrome we are talking about has a cutesy name. It's called pancake syndrome. So basically, this child saw the GP for anaphylaxis and was referred to children's emergency. So actually, she presented acute urticaria, angioedema, breathlessness. Fortunately, hemodynamics was still stable. Given IM adrenaline, came to CE, and then CE admitted her children's emergency, for monitoring. So same history, no much food allergy, drug allergies, mild allergic rhinitis. Nobody knows what happened. Further history taking, just said that, at home I ate my usual lunch, then I had some nice dessert. I love mug cakes. I made some mug cakes containing flour, chocolate chip, sugar, and egg. I ate the same thing before, no problems. I'm very well previously, no intercurrent illness, no exercise, no stressors, and no other cofactors. So then what is the trigger for this anaphylaxis? And in fact, when we saw this patient in the inpatient CE setting, we were referred by the general pediatrician for idiopathic anaphylaxis because they said, I don't know what's the cause. So what this kid probably had was that of pancake syndrome, which basically is a cutesy name for oral mite anaphylaxis. So this is a severe allergic reaction that can occur shortly after the intake of food made with mite-contaminated flour. And these are not house dust mites, these are storage mites. So the common symptoms are that of breathlessness. They can get facial or laryngeal angioedema, wheezing, or veils. The food that's made with contaminated wheat or corn flour, especially pancakes in the Singaporean local context, are commonly implicated. So some of you may ask, what is this contaminated wheat flour? So basically it's something as simple as to open a packet of flour to make some pancakes for yourself. They put it in the fridge, keep it inside your pantry for a few weeks, and then storage might screw with it in a hot and humid climate. So the diagnosis is made based on the symptoms of the intake of food prepared with stale flour. And when you look for Ig sensitization to storage mites, these patients can be sensitized. If you prick to the suspected flour, so they have to bring back the same bag of flour, the skin prick will be positive, and then if you get another whole new bag of flour and prick to that same flour, it will now be negative. And actually, if you look under the microscope of the suspected flour samples, you will see that there are all these easy storage mites inside the suspected flour. Yep. And with that, I come to, so some of the take-home messages that I hope you all will find useful in the talk today would be that Ig testing supports and never replaces a good clinical history. Sensitization is not equal to allergy. I think this point has been driven home a lot of times today so far, so I won't belabor it. avoid screening panels, and low positives can be clinically irrelevant, so don't react to them. And when in doubt, you can always refer to the allergist. And to me, the biggest risk of doing too much IgE testing is actually not missing allergy, it is overdiagnosing it. Because sometimes overdiagnosis is actually doing the patient more harm than good. And with that, I come to the end of my talk today.
Dr. Peng for that really excellent presentation. I'm sure a lot of you can take back what she spoke on and apply it into your clinical practice. I'm sure it has helped me a lot too with my experience with allergy. Okay, so next I would like to go to our final speaker today. Okay, great. And our final speaker this afternoon will discuss the advances in IgE testing for airway and drug allergy. It is my pleasure to introduce our final speaker. Dr. Grace Chan is an experienced allergist and clinical immunologist with a special interest in drug allergy and desensitization. She completed her specialist training in rheumatology, allergy, and clinical immunology at Tan Tock Seng Hospital, Singapore, and is a fellow of the Academy of Medicine, Singapore, and the Royal College of Physicians, Edinburgh. Dr. Chan further advanced her expertise through specialized training in drug hypersensitivity and desensitization. She previously served as senior consultant and led the allergy and clinical immunology service at Tan Tock Seng Hospital. She is currently president of the Allergy and Clinical Immunology Society Singapore, contributing actively to the advancement of allergy care and patient outcomes. Today, she'll be speaking on advances in IgE testing for airway and drug allergy. Please join me in welcoming Dr. Grace.
Thank you for the kind introduction. By the way, I'm not the president anymore. The president is Dr. Chong here. Dr. Chong Gok-wee from KK Hospital is the current president. Yeah. Okay. Okay. So I am currently in private practice. I'm no longer in Tan Tock Seng Hospital. I've been in private practice for about 2 years plus now at Elim Rheumatic Center. So I'm trained as a rheumatologist. Currently, there's no accreditation for allergy and clinical immunology under the Singapore Accreditation Board. So most of us who are allergists, clinical immunologists are either rheumatologists or like Dr. Chow. There is an internal internist. So and some dermatologists, respiratory physicians also do allergy and clinical immunology. And majority still the rheumatologist covers allergy and immunology. So today when I talk about advances, actually the truth is hardly any advances. That is true, but thank you Anton for talking about the component, which is probably one of the better breakthrough in measuring specific IgE. But the truth in the allergy space now, in practical sense, measuring IgE is still fairly limited, other than the food allergy and the dust mite allergy part. Yeah. So in allergy condition, the main issue is T2 activation. You always hear T2. You go to a lecture on basic sciences of allergic diseases. It's only T2 activation. T2 activation starts with the B cell. B cells present to the T cell. The T cell present to the B cell, and the B cell produce antibodies. Be it in autoimmunity, allergic diseases, production of abnormal antibodies is a key issue. And what drives allergic disease is inflammation, and inflammation driven by interleukin-4/13. So there are lots of advances now using biologics treatment for allergic diseases targeting interleukin-4/13 to treat allergy, and also anti-IgE, like what Dr. Peng has explained in omalizumab, is also recent advances. Okay. So the molecule of IgE has been discovered a long time back. But IgE is a molecule that we shouldn't be there in the first place. It's our body developed antibody against parasite against bacteria, viruses, mainly IgG and then IgG. But IgE usually is mainly developed in allergic diseases or parasite conditions. If you see some patient with very high IgE, we have to be aware of whether it's a parasitic infestation or the patient has hyper IgE syndrome in the immune deficiency case. Okay, so IgE ranges, lots of range. You look at it, sometimes can be quite confusing. Yeah, but it gets higher as the patient age. And the severity, very high IgE suggests something. But sometimes patients are totally asymptomatic, even with very high IgE. I don't have some patients incidentally find very high IgE but totally asymptomatic, no allergic diseases at all. But very high IgE sometimes will point towards certain condition that we need to be aware of, especially parasite infestation or hyper IgE syndrome, which is a very rare syndrome. Okay. So when we do allergy testing, we always start clinical. I prefer not to do allergy testing to look for the condition, I'd rather do allergy testing to confirm what the patient has. So the patients usually present with a clinical symptom that suggests of a high IgE-mediated reaction, and it's usually rapid onset, occurring within minutes to an hour after exposure. And a very rapid response is either can range from a local reaction to a systemic anaphylaxis. Of course, the worst spectrum will be anaphylaxis. And because the recurring episode with the same trigger is also the key to the manifestation of an IgE-mediated reaction. And atopic dermatitis is also an IgE-mediated reaction, but it's a chronic condition. So sometimes it can have a variant of a clinical manifestation that's not totally just rapid, like urticaria and angioedema. So atopic dermatitis is also one of a chronic condition of an IgE-mediated reaction. Okay, not all allergic-like manifestation is an allergic disease, and there are some conditions that are like pseudo-allergy that can present like an allergic reaction, but it's not an IgE-mediated reaction. So a true allergy requires activation of the immune response and a detection of IgE or a T-cell activation, especially in drug allergy. Okay, and now we only have either skin testing or detection of specific IgE to allergens is the only commercially available test now available to detect an immunological response. So we only have two tools, either skin test or blood test, which is IgE. You can test the total IgE and you can test the specific IgE. Sometimes I do both, sometimes I just choose to do the specific IgE. Okay, so this is one case that I look after. He's a 33-year-old Chinese Vietnamese male born in Australia and came to Singapore 2 years ago. He has very bad allergic rhinitis as a child, outgrown his asthma, has immunotherapy done in Australia, and then after completed 5 years and doing well, and came to Singapore, and his allergic rhinitis got worse with allergic rhinoconjunctivitis. So both he has got eye symptoms and got nasal symptoms. So he's and then he's confused. He thought his dust mite allergy is cured. So now he's getting a lot of allergic symptoms. He came to my clinic to ask for advice. So I run his, I think this is next one. Okay, this is the initial specific IgE. You can see polysensitized. Plenty of sensitization, more than 0.35, right? Plenty of them more than 0.35. His dust mite specific IgE highest for TP, DF mainly, okay, and a little bit of Blumia tropicalis. So he's still, this just shows sensitization. Whether is it dust mite that is the main driver of the allergic symptoms is hard to tell, but I still think it's dust mite, especially when you move from Australia and stay in Singapore. In Singapore, humidity drives lots of dust mite allergy. Almost 90% of our patients with allergic rhinitis are driven by dust mite. And I think the major allergen is still DP in here, although Blumia tropicalis is also one of the culprit here. So I suspect it's probably more DP and DF dust mite allergy here. That's the culprit of his allergic rhinitis and conjunctivitis. Okay. So this gentleman went through immunotherapy with 3 mites. I decided to choose 3 mites for him. Since he has already had the immunotherapy DPDF, I thought that if I give him DPDF and then if it doesn't get better, then I have to switch. So I just gave him 3 months immunotherapy, sublingual, and he did okay, but eventually not so compliant, so I switched him to subcutaneous immunotherapy. So this was his latest, after 1 year of treatment, his latest specific IgE. So shows that it's still there, but a little bit lower compared to his pre-immunotherapy. We don't have specific IgG4 here, so I still based on symptoms to see the effectiveness of immunotherapy. So this is my recent patient, a Filipino lady, 31 years old, born in Manila, persistent rhinitis symptoms, use lots of Avamys, antihistamine, but with very limited response, unable to determine what the specific trigger. The onset was 2 years ago. There's no childhood ectopy. So when I measure her specific IgE, it shows that her total IgE is very high, 1,000. But her specific IgE all negative. So I was saying, wow, this one I think is most likely dust mite, but somehow her dust mite specific IgE all negative. Maybe we should measure a component for this lady. We probably may be able to find what the possible trigger is. So sometimes I do encounter this type of patient where the total IgE is very high, but the specific IgE for the inhalant allergen is all negative. Even the skin test, I think the skin test is also all negative. Yeah. So sometimes the blood test negative, I will proceed to a skin test just to be sure. I do have patients that blood test doesn't show anything, but the skin test showed positive test. Okay. So this is another patient, 16 years old, born in China. I like to ask them where they are born, so I kind of establish a kind of sensitization on which location or which area. Okay, so he born in China, had persistent rhinitis symptoms, no nasal polyps, recurrent conjunctivitis, have childhood asthma, eczema. Now he lives in Brunei, and at some point in time he was, I think his childhood, early teenage, no, this one was early childhood. There was a period where he lived in Canada. So he's supposed to go back to Canada for college. So the mom said, you have to treat his rhinitis before he goes back to Canada. So I did his pollen, because I think pollen is most likely the allergen for him. So look at the pollen test, all positive. Yeah, all polysensitized to all the pollen. There's some tests done in Brunei that shows all this evidence positive. Yeah, nuts, vegetables, or this is a classical case of polysensitization in a patient who has got childhood ectopy. Yeah. So I tried immunotherapy to pollen for him. In Immunotech sublingual immunotherapy, you can customize it to 4, maximum 4 allergen in 1 bottle. So I've yet to see any results. I have to wait until about 3 to 6 months before I can see any improvement in his allergic rhinitis. Okay, so just now, Dr. Peng did talk about cross-reactivity between dust mite and shellfish. This is the issue in our region here. It's because of the very high dust mite sensitization, shellfish allergy becomes an issue. a lot of oral allergy syndrome, and also sometimes with cofactor, patients can progress from oral symptoms to even anaphylaxis. So in adult allergy, sometimes it's very unpredictable. Patients say, I can eat shellfish, but one day they just eat laksa or eat gen noodle and they develop anaphylaxis. And I ask them, what happened? Do you have a vaccine before? Do you have viral infection? Do you have alcohol? Do you exercise? I ask all of them. And I find that PPI is one of the possible cofactor. I have patients who have plasmide sensitization, went for a scope, and the gastro 5H pylori give PPI, and then the patient might eat laksa and then develop anaphylaxis the same night. So, and he has been eating laksa all the time, no problem. So I feel that probably PPI may be the cofactor, or stress from the scope or something. Yeah. So in adult allergy is highly unpredictable. Sometimes patients present with very bad allergy, and maybe a one-off event or cross-reactivity or a cofactor issue. So you can see that shellfish, crustacean, or the bolus, they all have the same allergen, tropomyosin. And the major allergen cross-reactivity between the mites, the storage mites, crustaceans, shellfish, or if the major allergen is tropomyosin, then they may have this issue. Okay. Storage mite, the case pancake syndrome that Dr. Peng discussed just now. Quite common, I see a lot of storage mite allergy in my practice. I do skin tests to storage mite allergens. In fact, Dieta has the allergen if you want to explore using skin testing to storage mites. Okay, they have 3 species available. Usually I use the 3 species of storage mite, and Blumia tropicalis is also a storage mite. Okay, so tropomyosin is a very important. We can do component, we can measure DP10 that can help to see whether tropomyosin is a major allergen here. Okay, so nothing here. Okay, so this is one study that shows that in the Jewish people who have never eaten, Jewish people can't eat shellfish, right? And yet they detect IgE of shellfish in them because of cross-reactivity with plasmid. Okay, so sometimes can be hidden sensitization. Okay, right. Skin testing is one of my go-to tests if the patient hasn't taken any antihistamine. Okay, so this is a patient who has got allergy to dust mite as well as storage mite. Okay, you can see that this patient presented with like a food-induced anaphylaxis. We think that the culprit initially was prawn, but when I do the skin testing, the patient actually has high sensitization to the 3 dust mite and 2 of the storage mite. Yeah, and when we introduced prawn in his diet later, he can tolerate. So it's probably cross-sensitization with cofactor that was the problem. Okay. Let's move to drugs now. Okay, so drug allergy is one of my special interests. Food allergy, drug allergy has 2 main types. One is the non-immune mediated, one is the immune mediated. And the immune mediated is either IgE or non-IgE. You just remember it that way to make it simple when you see a drug reaction. Okay, for the IgE mediated reaction, if it is driven by the mast cell release histamine. Histamine causes angioedema urticaria. If the patient presents with acute symptoms, swelling, hives, then it's really driven by histamine. And if it's driven by histamine, it can be IgE, it can be non-IgE. Okay, so there are many targets. There are direct, like vancomycin, the atracurium, ciprofloxacin can directly degranulate the mast cell without involving IgE. So if you give first dose of ciprofloxacin, sometimes patient can present with urticaria. So and the problem with drug allergy is that testing is very limited. testing is very limited, and sometimes the drugs I don't have skin testing, and there's no specific IgE. Okay, so drug allergy has got 4 types mainly. Type 1 IgE mediated, type 2 they are complement or IgG mediated, type 3 immune complex, type 4 delayed hypersensitivity like the papular rash. Okay, so type 4 actually is the most common type of drug reaction that usually we encounter. Okay, when we do drug reaction, start with the reaction, then move towards what is the onset, whether it's immediate or is it delayed. My cut-off is usually about 6 hours. Okay, I know the guidelines say 1 hour, but because oral treatment sometimes absorption takes about 6 hours. So take about 6 to 12 hours as your immediate the onset. Then the next day or 3 days later, 5 days later, then it's called delayed reaction. Okay, then you move towards the drug and the host factor, whether the patient has like ectopy, whether the patient has got chronic spontaneous urticaria, the genetic and the renal function, those can help with identifying. And the reaction, whether it's a serious, non-serious. Okay, serious, the most serious one is TEN, SGS-TEN, and of course the immediate one is anaphylaxis. The rest, just mild rash, not serious kind of reaction. So if you classify it like this, then it's easier for you to kind of figure out what the problem is with the drug. COX-2, NSAIDs hypersensitivity is one of the most common type of drug reaction. Patient take ibuprofen, paracetamol, Voltaren, Simplex, gets periorbital swelling. That is the main, that's one of the most common, what we call NSAID-induced hypersensitivity. Eyelid angioedema, about close to 90% of the patients with NSAID hypersensitivity. Urticaria, angioedema, urticaria not so also frequent. Angioedema is most common for NSAID hypersensitivity. From the Tangasin data that we have previously shows that about more than 90% of the patient presents with angioedema for NSAID hypersensitivity. And generally they are cross-reactive, so they can't take all the NSAIDs, including sometimes paracetamol. But fortunately, about 99% of them can take COX-2 inhibitor. For this type of reaction, no testing. You send to my clinic, I tell patient no testing. No blood test, no skin test. Okay? I give them alternative. Don't take NSAIDs because sometimes can have anaphylactic reaction if they are lucky. What they can do is they take an alternative, either indoricoxib or celecoxib. They usually can tolerate up to 99% of each time. I give them a challenge test in my clinic. I say you just use alternative COX-2 inhibitor. Very seldom we encounter selective NSAID hypersensitivity. Means that the patient only sensitive to one group, chemical group of the NSAIDs, like only the Buford group or that group. So sometimes they can take another group. Like patient can take Podstar, but they cannot take diclofenac. So the patient have that kind of history, and I say, okay, you just stick to Podstar. Don't take diclofenac. Okay, so I can't do any testing. There's no blood test to tell. Recently, some of the allergy specialists or the specialized group will do basophil activation tests, but we don't have this kind of commercially available. So, and I also don't want, in the practical sense, I want to order a basophil activation test for NSAID hypersensitivity. Okay, maculopapular rash, tiny rashes like this, like measles kind of rash, is the most common type of drug reaction for antibiotics, especially the penicillin group of antibiotics or the beta-lactam antibiotics, allopurinol, sulfasalazine. These are and some of the other beta-lactam antibiotics can present like this. These are delayed hypersensitivity. Okay, you can see that sometimes when the patient takes amoxicillin, you can see that the patient can have different type of delayed reactions. They can either have like a psoriasis, like the pustular psoriasis type of reaction, or called AJAP, or can have maculopapular eruption, SGS dress. Sometimes patients need prolonged antibiotics. That's when the problem starts, and you can present with a more severe kind of reaction. Okay, I typically see sometimes patients with H. pylori treatment. By the time they hit the 7-day to 10-day mark, they start to get rash because of the sensitization to the amoxicillin. And generally, amoxicillin, the problem is the side chain. Sometimes patients still can able to tolerate the other beta-lactam. So good to do some cross-reactivity kind of test. Okay. So this is a chart. It's very useful that I use in my practice. If the patient have a beta-lactam kind of antibiotic allergy, I look at the chart of what we call the side chain reactivity. If the patient have a delayed hypersensitivity, because of lack of testing, patch testing is not very useful. Blood tests, not useful. So the only way is to use my side chain chart to see which one I should avoid for the patient and which one I will try to challenge to see if patients can tolerate or not. Okay. Remember that amoxicillin very more commonly used, right? Amoxicillin cross-react with ampicillin and cephaloxime. Oral, we use oral antibiotics quite frequently for tumor infection. We either give amoxicillin or give cephaloxime, or sometimes we use Classil, etc. But cephaloxime and amoxicillin share the same side chain, so just be careful. Right? You want to use an alternative if the patient has amoxicillin rash. Okay. Okay, so this is just another one that sometimes I highlight to see which one I will want to avoid and which one I can give. Okay, generally for beta-lactam, patients have amox MP label allergy, avoid cefalexin. If the patient has cefepime, ceftriaxone, this cefotaxime, this is the one we group. If the patients have ceftazidime, it cross-react with estrogen. Okay. You guys don't work in the hospital setting. The hospital setting, all these are mostly the IV antibiotics, except for the amox and cefalexin. Yeah. So if you encounter patients who have got beta-lactam antibiotic allergy, this is the cross-reactivity that we look for. Okay. And the one good thing that we use cefazolin a lot because of treatment of cellulitis or some of the gram-positive infection, it doesn't have any shared side chain with penicillin or the other cephalosporin. So it's actually a good alternative for a patient who has got labeled penicillin allergy. Okay, this I do skin testing for penicillin allergy, skin testing and intradermal test. You can see that the patient has this PPL, MDM, they are the major and minor determinant that measures the beta-lactam ring reactivity. If the patient has PPL, MDM positive, then I have to be careful whether the patient have cross-reaction between all the other beta-lactam antibiotics. Okay, this is a patient that was referred to me after a shoulder surgery that has multiple bullous eruption after discharge. Big giant bullous eruption. And she was given etoposide, augmentin, gabapentin. So the orthopedic surgeon said it's gabapentin. Please assess this patient for gabapentin allergy. So I said, okay, I'm not sure it's gabapentin or not. Let's evaluate them. Okay. So I did the skin testing. I know this bullous eruption during skin testing not so helpful, but sometimes delayed intradermal testing still can help. Just a negative skin test. So I said, let's challenge the augmentin. Soon after I challenged augmentin, 12 days later, the same site came out with the milder. Just confirmed to have augmentin allergy. Yeah. So see even my skin test can't pick it out, so I have to challenge it. Challenges involve risk. Fortunately, this small dose, one tablet, bring out the reaction rather than serious. So she just have to take a short course of steroids to cure the rash. Okay. So yes, she can take other beta-lactam in future, but just not with the similar side chain. Okay. All right. So the blood IgE testing, I find that for a drug not very helpful. We only have very limited. Quest your catalog, right? Only have penicillin, amoxicillin, and for blood allergy testing, and even that the sensitivity or the specificity is very low. Okay, still clinical judgment is still the best way for drug allergy. The advantage for blood IgE testing is that it's not affected by antihistamine. If the patient has been taking lots of antihistamine, I would go for the IgE testing. You can't do the skin test. Patients with long-term steroid use, specific IgE is still better than skin test. And patients with bad skin, so I also don't do skin testing or do the blood test. Okay. For drugs, only a very limited number of drugs. I show this paper here. This paper here shows that penicillin, amoxicillin, some neuromuscular agent has morphine. Very difficult. Morphine is also another drug. It's very difficult to test because it's very irritative. Yeah. By skin test, very minute amount can induce a wheal. So and false positive is very high. So probably IgE testing may be useful for morphine, but we don't have that. I think no lab is offering this morphine. And I heard from Anton that chlorhexidine IgE that is that's available. Latex IgE is available. So these are only a very handful of blood tests available for blood tests for drug allergy. Okay, inside venom is also important. Just highlight the inside venom specific IgE is quite important. Yeah, wasp, hornet, bee venom that we can do the specific IgE. Okay, key message here. Specific IgEs just suggest sensitization may not necessarily be clinical disease. I think the best, still food allergy for specific IgE for now, and measurement of the components will be very helpful. So the higher the level, maybe more clinically relevant. Whether it suggests severity is not very sure. Sensitivity, especially for drug, not that good for now. So in the end, for allergic disease, still clinical plus testing or sometimes challenges is the way to go for now. Okay? Yeah, that's all I have for today. Thank you.
So, okay, we've heard a lot about evidence-based allergy testing strategies, food allergy interpretation, and advances in IgE testing for airway and drug allergies. So I'd like to start with a few questions for the panel. I think a number of you have submitted your questions as well. So without wasting time, I'm just going to go straight to the questions from everyone here today. Okay, the first question is there a phenomenon of cold air or temperature change allergies? Okay, maybe
This, I don't know which, what organ you are referring to. Is it airway or hives? Usually when someone is like, explain the pathophysiology of allergy, right? It has to be immune mediated. So the immune system only can detect protein, unfortunately. And I don't know whether how to develop IgE against. So to say allergy, maybe not, but you can develop hives. We can what we call physical urticaria. Patients get urticaria from cold, pressure, or even temperature, change of hormonal, they are not allergy, but they can present light allergy. Yeah. So there is a phenomenon called physical hives that possibly this one some right. And for nose, sometimes I have what we call vasomotor rhinitis. Can hot, cold emotion can drive the allergic rhinitis symptoms. Okay, they're not allergy, but they're called what we call non-allergic like kind of allergy symptoms. Yeah. So this is something that sometimes we do encounter in clinical practice.
Thank you, doctor. Something like pseudo-allergy. Okay, thank you so much for that question. Okay, so I'll channel my next question to Dr. Peng. If parents have severe shellfish allergy, how likely is a child to have it too, and how would you advise patients and parents who are afraid to introduce shellfish?
Yeah, so I think this question does come out in the pediatric population quite a fair bit, because a lot of times the parents have some history of like allergy to something, and then they are worried it's genetically transmitted. Of course, I would never say that it's 100% not genetics. For all the atopic conditions in general, there is an element of genetics. However, there's also the environment. And I always tell the parents, it's not directly translatable. It doesn't mean that you have a shellfish allergy, your kid confirmed plus CHOP would have one. But a lot of times, I do understand the social context. They are worried about it. Some of them have very bad reactions before. So the psychosocial factor there is that they're very scared about it. Then with regards to introduction, or if they're very worried, so when they come to see us in primary care setting or versus specialist settings, of course, if they're already very worried, we can still offer them the skin prick, the IgE, because if it buys them a negative result, sometimes it buys them that peace of mind. However, what we can also offer in a specialist setting, if there are some parents who are so worried, we tell them if you want to do it, don't do it as a food challenge, meaning that you come to hospital under the supervision of the doctors and nurses, we feed your child and that the food, and it buys them that reassurance and confidence that they are okay with it. Because I had one patient, of course this is a bit dramatized, I told them to go home and introduce the food. Subsequently, at the next appointment when they saw me, they said, actually doctor, I ate it at home, but I was so scared I ate it in children's emergency. I took the food, I brought it, I sat outside, I ate it, finished it, I passed, I went home. And then I was like, oh, I didn't know it was so traumatic for you. If they had told me, I'd rather you do it nice in a clinic setting. You don't sit there and then like tremble in fear all the time, kind of thing. Yeah.
Thank you so much. I think for peds it's a little bit more intense because parents are very anxious, right? So I think we see that quite often in our practice. All right, my next question is from Mr. Anton. From experience across different countries, are there notable trends in allergy prevalence or testing patterns in Asia?
I think in terms of things like dust mites, certainly I think this is something that causes great concern in Asia. And then of course food allergies, and I think you have some quite unique food allergens in this region as well that we don't necessarily see in other parts of the world. I mean, if I go out here with some of my colleagues, I do encounter some interesting foods. But I think cross-reactivity is probably the one thing that's causing major concern and major confusion in food allergies. So, in many parts of the world, the trend is in a direction of molecular allergology. If you attend any of the major conferences, that is what they talk about. And I think that's also something that will develop here and become much more prominent in the future.
Thank you, Mr. Anton. All right, I think we have quite a bit of questions, so I'm going to rush through them. The next one's to Dr. Grace. Dr. Grace, for case 2, the one that you presented just now, high total IgE, no specific antigen, could it be parasitic infestation? What was your management?
Yes, the IgE is high, but it's not like extremely high. So based on the symptoms, right, I don't think it's parasitic. For patients I suspect like possible parasitic, can send stool for over cysts, or sometimes can just if the patient have eosinophilia, if I do full blood count, I like high eosinophils, then high eosinophils can react to pills. Yeah, if it's very high, I can give them a course of albendazole, just a step dose. If I'm not sure. Yeah.
Thank you so much. Okay, my next question, perhaps Dr. Peng can answer. For dust mites triggering allergic rhinitis, how would you advise your patients and how do you manage them? For dust mites triggering allergic rhinitis, how would you advise your patients, I mean not patients, your pediatrician, right? So parents, and how do you manage them?
So for dust mite triggered allergic rhinitis, of course the usual symptomatic treatment with allergic rhinitis still applies, regardless, such as those of the topical intranasal steroids or antihistamines. And then in peds, maybe, I don't know whether there's something specific to peds, but we're very good at nagging our patients about house dust mite avoidance measures. We have an entire brochure. I always tell them points A to I, go home and slowly read through it, but I'll go through the brief things with you. But so something that may be applicable to the general GP setting is that house dust mite avoidance measures. In general, we tell them to wash the beddings in hot water more than 60 degrees weekly. And on top of that, they also have to get rid of the furry soft toys. I guess that's not very applicable to adults. As well as fluffy blankets, service the aircon regularly, HEPA filter. So in general, I always tell them, you just make sure auntie is very hardworking or mommy is very hardworking, because then all the eyes will pop up when you hear about how drastic the house dust mite avoidance measures are. Then in terms of the management, apart from the intranasal steroid antihistamines, which I'm sure the adult ENTs or the GPs are very familiar with, the other thing that allergists we offer, both in the adult settings as well as pediatrics, is that of oral immunotherapy in terms of SLIT. So we do, and I think the GPs are very familiar with it because we often always get a lot of referrals from them asking us to consider the patient for SLIT.
Thank you. I think adults also have furry toys. So, okay, thank you so much for that answer. Okay, my next one will be for amoxicillin allergy, can cefuroxime be given?
Cefuroxime and amoxicillin do not share the same side chain. If I want to be sure, I'll give a cefuroxime challenge test. Cefuroxime now, I think we don't use it that frequently. I know some of the urologists still use it for UTI, but we use cefuroxime very rarely now. But there's still the brand Zinet, I think. Zinet that sometimes used. Not clear, I would drug challenge to the cefuroxime.
Alright, thank you. Next one would be for Dr. Peng. For the child with positive tests for egg and a bit of peanut allergy, should the child be referred and what will be done?
So I think you're referring to one of the cases that was mentioned earlier. So that kid had egg allergy and there was some peanut sensitization because there was some positive IgE on the peanut, but the child has never eaten peanut. So then in that case, usually we will see them in the specialist setting in KK. Of course, if there's egg, then we will go down the egg allergy management. We would ask them to avoid egg and that is a different thing. For peanut, on the other hand, given that there was sensitization, but then we have not shown whether the child is tolerant or not. If the child comes in the history saying, and some of them do, I have a sensitization to peanut, but I'm eating peanut butter every day, I love it with bread, then we tell them go ahead, just continue eating. Then there's no need for further testing, you're clinically tolerant to the peanut. But if there's no history of ever eaten it before, which is very common, because for some reason the Asian context parents are very scared of peanuts and never introduce it to the child, then what we would then usually do is, some of us will want to do a second testing IgE to look at how it looks like compared to the skin prick. But if the parents are adverse, and one way to do is to do it as an oral food challenge. So the kid comes to the hospital in a separate setting, and then we actually give the child peanut ingredient dosing in terms of the allergen dose. And it's what we call a diagnostic challenge to assess whether the child is truly allergic to peanut or not.
Thank you for that. Okay, I'm just going to take two more questions due to time. So my next one would be, how is a patient with a drug allergy managed when the bacterial infection has limited antibiotic options based on the sensitivity results?
You mean the patient is not sure what allergy it is? They mentioned, okay. So the typical scenario that I usually get case that refer to me is patient has a multiple drug allergy. let's say penicillin is labeled, ciprofloxacin is labeled, and clindamycin is labeled. But then it's very difficult, right? Usually end up either using gentamicin or vancomycin or something like that, or daptomycin if they are very severe reaction. This is multi-resistant, right?
Yes.
Multi-resistant drug. Okay. Okay, let's say, usually multi-resistant drug, almost always usually UTI, right? UTI, multi-resistant, quite common. Patients usually end up using gentamicin, or if very bad, they're not sure, they refer to me, then I say, can I use a tapeno, or can I use one of the beta-lactam antibiotic like proserpine or something. Or for patients like that, usually I will establish what the index reaction to the drug that's labeled allergy. If the index reaction is not a serious reaction, like some non-specific rash or cannot remember what was the reaction, I will just do a drug challenge. Yeah. Let's say the urologist wants an ertapenem or the ID wants ertapenem, I'll just challenge the patient to ertapenem. I don't do the skin testing, there's no IG testing, just direct drug challenge. If pass, just complete the antibiotic. If the patient has got anaphylaxis to penicillin, then our skin test. Our skin test, if the skin test is negative, there is a 95% negative predictive value, so the patient can go through a challenge test.
Okay, that brings me to the last question. How do we give drug challenge tests in a GP setting? Can we do that in a GP setting?
The only drug that you can do a drug allergy testing if the index reaction is completely like I don't know, or allergy, patient that diarrhea or some kind of totally non-allergic kind of reaction. You want to choose to do a drug challenge, you can do it, but you have to document down the documentation and discuss the risk and benefit with the patient. Can be done like etoricoxib. I know that NSAID hypersensitivity very common, right? Sometimes patients need painkiller and then you don't have a lot of options. I know some GP do give etoricoxib and send the kid outside every which is not what I do in my own clinic. Also, patient just take one dose of 90 milligram of Coxia and just sit outside the clinic for one hour. And I said, okay, can they use this as the alternative? In fact, our data shows that 99% chance can pass. If the patient have the index reaction is angioedema, sometimes patient can have like puffy feel even with etoricoxib. Yeah. And then if the patient is very scared about it, then no choice after you have to admit the patient. I have to admit the patient and do it for just to assure the patient that she is like will know how to intervene if she has a reaction. Yeah. Generally, select your patient carefully if you choose to do it. If anything, if you are not confident, always refer to the allergist. We have ways and tools to safely challenge the patient in our clinic or in the hospital.
Awesome. Thank you so much to all our panelists here today. If you have more questions, feel free to ask them personally as well after this. And so let me just close this off by, I would like to say on behalf of the organizers, I would like to extend our sincerest appreciation to all our distinguished speakers for sharing their expertise here today. We would also like to thank InnoQuest Diagnostics, Biomed Global, and the Allergy and Clinical Immunology Society Singapore for supporting this educational program. And finally, thank you to all of you for joining us here today. And we hope this session has been clinically useful and relevant to all of you. So thank you very much and have a wonderful evening. Thank you very much.